All right, well, thank you to Dr. Jackson and Dr. Olasky for asking us to come and give this talk. Let's see, here we go. So how many people in here are members of the Facebook group? Who's here to learn Foregut and who's here to check out what the Facebook groups are like? Okay, so about half and half. Lots of the faculty I can see because I recognize all their names. So this is a really great network. It's a way for you to get almost instantaneous feedback and support, which I think was mentioned by one of the speakers a little bit earlier. It makes you feel better about the decisions that you made. But making this talk, I just pulled up the group. I searched for just pseudo in the search box there on the bottom left, and you can see all the posts that come up. And this pseudo-achalasia is a achalasia-like pattern of dilation of the esophagus, which is due to a narrowing that's something other than primary denervation. So we've talked a little bit already this morning about what achalasia is and what some of the features of it are, and I'll go through a few more of the details with us, but pseudoachalasia is going to be caused by something else. So this could be a Nissen fundoplication, a malignancy, other things. On endoscopy, there's going to be a difficulty in passing the scope. On a barium swallow, you may see mucosal irregularity of the mucosa from any kind of adenocarcinoma lesions that may be present. The endoscopy is going to be able to differentiate pseudoachalasia from achalasia about 75% of the time. So obviously all these patients need to have an endoscopy, and the endoscopist will be able to figure out whether the dilation seen in an upper GI or the reasons for the symptoms for dysphagia with the endoscopy alone about 75% of the time. The reason for that is that most cases of pseudoachalasia, if you do a PubMed search for this, are due to lesions of some sort. So about half of the three-quarters of the patients in Northwestern series were due to carcinomas that were found on endoscopy. In terms of radiographic appearance, you can again see mucosal irregularity if there's a carcinoma that's present. You will often see a temporary patency of the LES with the pressure of the bolus going down. We want to get a CT scan to look for a mass. So if you're not sure what the reason for the dysphagia would be, in correlation with your manometry, get a CT scan and think about extrinsic compression from different lesions. And I have an example of that coming up in a minute. Both achalasia and pseudoachalasia are going to have an abnormal IRP generally. And the IRP is the integrative relaxing pressure. I always have to look up how this is measured, but essentially what this is pressure over time at the esophagogastric junction. So if you're running the software, you make a little box. The box starts where the esophagogastric junction is located on the pressure waves, and the x-axis is going to be a 10-second window after deglutination of the swallow, so initiation of the swallow. During that 10 seconds, you take the 4 lowest time points within there, and taking the mean of those will give you the IRP. So if anybody's a math geek, this is basically the integral and area under the curve, and it gives you a slightly different, a different piece of information than would be just does the EGJ relax or not. So it's more of an area under the curve phenomenon, kind of like the DCI as an area under curve of the motility of the esophagus, and gives you a little bit more information than just looking at the colors going across. So we can differentiate between achalasia and pseudoachalasia with relaxation of the EGJ on the manometry or sometimes on the upper GI. There can be peristalsis, but most of the time with pseudoachalasia it's aperistaltic, which is why it's called pseudoachalasia. A lot of times the esophagus is burned out and amodal from the obstruction. Lots of different causes. Many of them are medical ones, and that's why this isn't really thought of as a surgical problem. Most of the ones that we're going to see are going to either be due to a stricture or a prior gastric surgery. But other causes would include gastric carcinomas, esophageal carcinomas in the cardia area, lymphoma causing extrinsic compression, lots of different neurologic diseases, brainstem strokes, amyloid, different kinds of intestinal pseudo-obstruction, complications of prior vagotomy. Strictures of the esophagus can cause these patterns on upper GI manometry. These can be related to ischemia, reflux, prior acid or peptic insults, and then scleroderma was mentioned a little bit already earlier, but scleroderma patients will have a patulous esophagus, which can be aperistaltic. A lot of times they'll lead to a lot of reflux symptoms, which can cause strictures, and this is more of a sclerosing problem. So we can find a algorithm, which I think is very helpful, and this is basically assessing somebody that's got atypical symptoms or dysphagia. In order to decide if there's an increased distal outflow pressure, we look for the IRP. The IRP is abnormal if it has higher pressure over time, as I discussed a minute ago. If you have an abnormal IRP, this can either be achalasia or EGJ outflow obstruction. The three different kinds of achalasia are listed there. Type 1 with no peristalsis, type 2, which is related to paraesophageal hernias and pressurization of the esophagus, and type 3, which are the spastic disorders, and these have different treatments on the left, including myotomy for variants of achalasia, and then considering of repairing the hiatal hernia if it's present, and then adjunctive treatments for spastic disorders. For EJ outflow obstruction, you can often still have normal peristalsis. You can have weak peristalsis if the esophagus is burned out. You can hypertensive peristalsis, and the patient just has a mass or some distal obstruction. The treatments for these are going to be to rule out things like esophageal eosinophilia, getting an EUS if you think there might be a mass effect there, and then considering doing things like dilations or Botox to try to see how the symptoms resolve with achalasia treatments in order to rule out pseudoachalasia as a reason for it. And so moving on to Facebook, this is all the information about pseudoachalasia, but you can get all this stuff in real time, and we have true wizards of manometry, not just here sitting having given us some talks, but they'll actually answer your questions while you're even in the midst of a clinic visit or seeing someone coming later in the day. So you can see someone coming in 2 hours to your clinic and post a manometry, and you'll have these guys commenting on it almost in real time. It's really fairly phenomenal. So Stephen Leeds put up this post of a patient with long-standing diagnosis of achalasia. The GI has scoped her and ruled out lesions, and he's puzzled because the IRP in this patient is normal. He does say that the tracings don't show relaxation, but then when he puts the tracings up, we can see the lower esophageal pressure is 25 up on the top right. It goes to a mean pressure of 10, so I thought this relaxed, but I think what he meant was that if you look at the actual tracings in the color graph, it doesn't appear like the LES is relaxing. He mentions that the IRP is normal, but this software doesn't report the IRP, and so if you can envision drawing a box around the green area after the deglutition and then measuring the 4 lowest points during that box, it would give you the IRP, and so I think it's normal because in this case the LES does appear to relax on the right side. So even though the LES relaxes here, people begin to discuss the manometry. Alex, who we just heard from, discusses calculating the median IRP. So the result that we're going to get is going to be a mean IRP, and he points out that if you get a high or low result in one of those 4 numbers, that you might get a spurious result, and recommends going back and looking at the tracings and calculating his own median IRP. I don't know if your rep has changed your software by now, but he says he's trying to get the software changed. Andrew says that he would call this variant achalasia. We have some suggestions here to try an injection of Botox. Dr. Ketan says it looks like achalasia to her, and we have Ed Aying asking about scleroderma. So that entire slide that I showed a minute ago showing the workup the workup and the etiologies for dysphagia and atypical symptoms is essentially summarized just in one quick discussion. Dr. Ramaswamy put up another case talking about a popping sensation with her EGD when she was traversing the LES on her scope. The patient has a slightly elevated Demeester score with elevated acid secretion or acid in the distal esophagus with no correlation of symptoms. The lower esophageal sphincter relaxes from 34 to 5, both of which are normal, but there's absent lower esophageal peristalsis. The GI doctors are calling it type 2 achalasia, despite the normal lower esophageal sphincter pressure and normal relaxation. So the question with type 2, remember, is whether there might be a hiatal hernia present, but we have patient with hyperacidity in the esophagus. And so there's a discussion about whether this could be achalasia or not. Some feel that because the LES is relaxing that it shouldn't be achalasia, that it's most likely reflux related. And Dr. Gata points out that this looks like an esophageal outflow obstruction, possibly from a hiatal hernia. Andy is wondering whether there might be a significant PEH and whether a CT scan should be done, and Common City's paranoid about pseudoachalasia anyway. And so once again, this slide sort of goes through almost that entire differential diagnosis, and the first slide that I found from the internet and some comments and just a few people. And then this was an interesting case that somebody posted where there was a large liver cyst. The cyst was known preoperatively. The preoperative manometry shows classic achalasia. And the question is whether or not the cyst could be causing the manometric findings. And he posted this case after having done the operation, which obviously he's doing a Heller myotomy here. But we can see comments talking about whether the pre-op CT might have let Dr. Gata know that that pseudoachalasia may be a possibility because of the extrinsic compression from the cyst. But others feel from looking at the manometry, which I didn't put in these slides, that this does appear, doesn't look like it would be pseudoachalasia to them by looking at the tracings. And so I think what all these demonstrate is that we can go online and find things like differential diagnosis graphs and algorithms to use, but these commenters in just a few posts, literally within a few hours, will draw out all the issues for you when you're looking at someone with findings which can be atypical or not suggestive of a particular pattern. It's nice to get more eyes on a problem. The speed with which we can learn with these groups is incredible. You know, just in a few minutes, you can gain the experience of people that spend all of their time learning these things, and it's very reassuring to know that you have a plan that's solid for your patient. So, in summary, thank you guys for the opportunity to come and present some of these cases, and I guess we're going to do questions at the end, right? Okay.